Whenever patient is coming with a shoulder pain, be it the anterior, posterior, whatever area of the shoulder, we have to do the complete shoulder evaluation. So components of the standard shoulder examination are the subscapularis, supraspinatus, rotator interval, biceps, AC joint, infraspinatus, posterior labrum. This is how the complete shoulder is examined anterior, lateral, superior, and the posterior part of the shoulder. Uh, just rebrushing our little bit anatomy. The shoulder is surrounded by the rotator cuff muscles. There are four rotator cuff muscles. Anteriorly, we have subscapularis from the subscapular fossa and attaches onto the lesser tubercle. Superiorly, we have supraspinatus coming from the suprascapular fossa, and it gets attached onto the greater tuberosity. There are three facets on the greater tuberosity. The superior-most facet provides the attachment to the supraspinatus. Then we have the infraspinatus attaching on the middle facet, and the posterior facet gives attachment to the teres minor. These are the four rotator cuff muscles which give stability and all the possible movements to the shoulder. In between these two, the greater and the lesser tuberosity, there is a groove which is called the bicipital groove, which is for the long head of the biceps tendon. Because this long head of the biceps tendon has an intracapsular origin, arises from the superior labrum, passes between the two tuberosities in between the bicipital groove. Okay, so here it lies in the rotator cuff interval. There is a defect. There is a defect in the rotator cuff all around all these tendons, but there is a defect through which passes the biceps, long head of the biceps tendon, and above it lies the coracohumeral ligament, and below it the superior glenohumeral ligament. This is how all the muscles, all the tendons and ligaments are there within the shoulder. Now, the first thing is to examine the biceps tendon. And for this, the patient is sitting with the hand resting on the thigh, and the probe, we keep the probe in the transverse position to the to humerus. So this is the transverse position of the probe in relation to the humerus. When we put our probe like that, we can see the two hyperechoic bulges. These are the greater tubercle and the lesser tubercle. This is the medial side, lesser tubercle. This is the medial side. This is the lateral side. In between these two tubercles lies the short axis of the biceps tendon, because biceps tendon is going like this. So when we put our probe in the transverse plane, we can see the short head with the biceps tendon in the cut section in the short axis. Okay, and this tendon is prone to anisotropy. If we
चले
toggle,
चलो
if we toggle the probe, we can see the black shadowing because of the because this tendon is prone to anisotropy. Okay, after examining the biceps tendon in the short axis, we rotate our probe in the long axis to examine the tendon in the long axis. In the long axis, we can see the hyperechoic bone, above which lies this nice fibrillar fibers of the short head of the biceps tendon in the long axis. We do both. We examine the tendon in both the short axis as well as in the long axis. So this is the short axis evaluation of the biceps tendon. One can see that biceps tendon is prone to anisotropy, and the greater tuberosity, lesser tuberosity. Then we turn our probe in the long axis and evaluate the bicep tendon in the long axis to look for any fluid around the tendon, any pathology, any tear, be it a complete or a partial tear, or the retraction of the tendon fibers. All the examination is done in both the short axis as well as the long axis. Okay. After that, again, we come to our first position. We look for the both the tuberosity and move our probe little needly so that we can see the coracoid bone. From below the coracoid bone, this is the tendon of the subscapularis muscle. But most of the tendon is lying beneath this coracoid bone. So when we ask the patient to externally rotate the arm, we can see the complete length of the subscapularis tendon in the long axis. The tendon is in the long axis. The complete fibers from here, from the subscapular fossa, it forms a tendon and goes and attaches onto the lesser tubercle. So when we put a probe like this, we can see the complete length of the tendon fibers when we externally rotate the arm. After examining the subscapularis tendon in the long axis, again, the tendon needs to be evaluated in the short axis too. We turn the probe and we see the tendon in the long axis. In the short axis. In the short axis, we can see the areas of the hypoechogenicity and hyperechogenicity in between. It is because the tendon is subscapularis tendon is a multipinnate thing. So we can see the muscle and the tendon intermingle in between. So this is the normal echo texture of the subscapularis tendon. Now look at the video. Here our probe is on the we were looking at the both the tuberosities, the biceps tendon, and after that move the probe little medially so that I can see the subscapularis tendon attaching onto the lesser tuberosity, and then ask the patient to externally rotate the arm so that we are able to visualize the complete tendon from beneath the coracoid process. Okay, this is how we examine the subscapularis tendon. After that, the very important tendon is of the supraspinatus tendon. Supraspinatus arises from the suprascapular fossa and it comes superiorly. It lies beneath the acromion process and goes and attaches on the superior facet of the greater tuberosity. The humeral head, it has greater tuberosity on which there are different facets. So supraspinatus tendon lies here on this superior facet of the greater tuberosity. To visualize, the most of the tendon lies beneath the acromion. So to visualize the complete tendon of the supraspinatus, we keep the patient's hand in the modified grasp position, which means the hand is lying behind the hand rest on the ipsilateral buttock of the patient, so that this humerus, it moves little forward, little anterior, so that the tendon you are able to visualize the tendon comes out from beneath the acromion, and you are able to visualize the complete tendon. Now for examination of the supraspinatus tendon in the long axis, we put the probe in this oblique position with one end of the probe toward the ipsilateral ear. So for long axis, the probe position is like that. One end is lying towards the ipsilateral ear of the patient and hand in the back pocket. And when we put our probe here, we see these are the anterior most fibers of the supraspinatus, which are attaching onto the uppermost facet of the greater tuberosity. And we examine the complete footprint of the tendon. The tendon has a broad footprint of about 2.25 centimeters long. So from anterior to posterior in this direction, we examine the complete breadth of the tendon from anterior to posterior. So when we move our probe from anterior most to the posterior, we see the contour of this tuberosity changing. Here it was like this, then it continuously changes and becomes more flat. This more flat, this provides that this is the middle facet, which provides the attachment of the to the supraspinatus, few fibers of the supraspinatus, along with these are the infraspinatus tendon, which is coming and attaching onto the middle facet. So middle facet provides attachment to some fibers of the supraspinatus and some fibers of the infraspinatus. So we need to examine the tendon in the complete width from anterior to posterior, anterior to posterior. So this is how the bone contour changes, and one can appreciate the complete tendon attaching on the greater tuberosity. After that, this was the long axis of the fiber, because fibers are coming like this and attaching here. After this, we turn the probe and to see the tendon fiber in the short axis. For examination of the short axis, we keep the probe in a way that one end is directed towards the navel umbilicus of the patient, right? So this is how we, in the long axis, the probe was directed towards the ipsilateral ear. In the short axis, probe is directed towards the umbilicus. So when we keep the probe in short axis to the supraspinatus tendon, what we see? We see the supraspinatus tendon. And if we move probe little bit medially, we can see the biceps tendon. More anteriorly will be the subscapularis tendon. Okay, and if we move our probe little posterior, we will be able to see the supraspinatus, and more posterior will be the attachment of the infraspinatus. So in short axis also, you need to see the complete from anterior to posterior. So this is how we examine the supraspinatus tendon. Here the hand, we are not placing the hand on the ipsilateral this hip, but we have rotated the humerus. We have made the position in a way that this humerus is rotated anteriorly. Okay. Now I'm moving my probe posteriorly, little up. So this is the direction to visualize the short axis of the supraspinatus tendon. So moving little up, and we are able to see the supraspinatus tendon. This is the acromion, the supraspinatus tendon. Moving little anteriorly, we can see the biceps tendon, and more anteriorly here will be this is the biceps tendon, and more anteriorly this is the subscapularis tendon. Okay, can you appreciate the complete evaluation of the supraspinatus in the short axis? Then we turn our probe, continuously turning the probe in such a way that the one end lies towards the ipsilateral ear. We see this contour of the greater tuberosity, where the anterior-most fibers of the supraspinatus are getting attached on the superior facet, and then we'll keep on moving our probe little posterior, anterior, and see the complete length of the supraspinatus fibers getting attached onto the superior facet of the greater tubercle. So this is the supraspinatus tendon. It has a broad footprint of 2.25 centimeter. That's why the evaluation has to be done along the whole length. Because most of the tears are there in the anterior most fibers. So you need to move your probe anteriorly till the area of the rotator interval, so that you are able to visualize the anterior most fibers of the supraspinatus, and then move posteriorly till we are able to see the insertion of the infraspinatus fibers too, because most of the degenerative tears are there at the junction of the supraspinatus and the infraspinatus area. So this is the coronal section of the greater tuberosity. Again, here we can appreciate there's a lesser tubercle, the greater tubercle, and in between the greater tubercle and the lesser tubercle lies the long head of the biceps tendon. The greater tubercle, there are three facets. The superior facet provides attachment to the fibers of the supraspinatus. The middle fibers, there are few fibers of the supraspinatus along with the attachment of the infraspinatus, and the inferior facet, it provides attachment to the teres minor. After that, we can palpate the clavicular bone and put the probe over the AC joint and look for the AC joint. We look for presence of any osteophytes here, any degeneration, or the capsular distension. We look for all the pathologies in the AC joint. Ask the patient to put the hand on the opposite shoulder and look for the widening of the AC joint to look for any stability in between the in the area of the acromioclavicular joint. After examining the acromioclavicular joint, see, we move probe little down so that uh, I'm able to see the this supraspinatus without moving the hand in the modified grasp position. Ask the patient to abduct the arm and look for any subacromial subdeltoid bursa, any fluid here within the bursa, and look for the movement of the supraspinatus tendon beneath the acromion. Look for the smooth movement of the supraspinatus tendon beneath the acromion, because in cases of adhesive capsulitis, you might be able to appreciate the fluid within the bursa. You might be able to appreciate that the movement of the supraspinatus tendons beneath the acromion is not very smooth. Um, uh, this is how we do the dynamic impingement. We look for the we in the resting position. We look for the acromion. We look for the attachment of the supraspinatus, and then we abduct the arm with the elbow flexed and look for the movement of the supraspinatus tendon beneath the acromion, and look for the presence of any fluid within the bursa. This hyperechoic line is the fat tissue between the deltoid and the supraspinatus, in where lies the SASD bursa. In normal individuals, we are not able to appreciate the bursa, but whenever there is bursitis, you will be able to see the fluid within the this collapsed bursa. So again, although this has been discussed, probe is on the uh, okay. So again, the short axis of the biceps, we look for the biceps tendon. When we then we move the probe in the long axis of the biceps, look for the biceps going up into the joint, then move the probe little below. See the biceps tendon till we are able to see the pec tendon in the long axis of the biceps tendon. We see till the pec tendon are there, because the tear in the biceps tendon, whenever there is tear in the biceps tendon, this gets retracted till the level of the pec. After that, again in the same position, move the probe little medial, look for the coracoid process, then externally rotate the forearm, look for the subscapular, this subscapular tendon, okay, in the long axis, subscapular tendon, externally rotate the forearm and look for the tendon. Then we move the probe in the short axis, look for the multipinnate nature of the subscapular tendon, okay. After that, we look for the AC joint, move our probe on the AC joint, look for AC joint, then put the hand in the back pocket and look for the supraspinatus tendon. From anterior to posterior, we'll look for the complete length of the tendon. And after that, look for the impingement, dynamic movement of the supraspinatus. And after that, we move the probe posteriorly and we look for the glenohumeral joint. This is the humeral head, the glenoid, the labrum, and this is how we complete the evaluation. Then coming to the rotator cuff interval, this rotator cuff interval, we keep our probe like that. We examine the biceps in the short axis and keep on moving our probe little up and turn the probe little oblique so that the medial end is towards the subscapularis, and lateral is we see the supraspinatus, and in between lies the hyperechoic fibers of the biceps tendon. In the rotator interval, lies the biceps tendon. Above is the coraco. This hyperechoic thing is the coracohumeral ligament, and which merges with the supraspinatus tendon. And below the biceps tendon, this is the area of the superior glenohumeral ligament, which merges with the subscapular tendon. So this interval is very important in cases of adhesive capsulitis. One can see the coraco thickening of the coracohumeral ligament. There'll be neovascularity in the area of the rotator cuff interval, and this is a site for we can anteriorly we want to do the joint injection. We can come here, we can come from this side, and just below the coracohumeral ligament, we inject the fluid so that it goes through this tendon, it goes into the joint space. Okay, this is also a basically area rotator cuff interval. This is area where we can do the joint injection from the anterior approach. After that, we palpate for the spine of the scapula and move our palpate for the spine of the scapula and keep our probe on the spine of the scapula and move little down. We are able to see this humeral head giving attachment to the infraspinatus tendon. This is the more medial thing. This is the humeral head, the hyperechoic fibrocartilaginous structure, which is labrum. This is the glenoid, and this is the this curved thing is the spinoglenoid notch, where lies the suprascapular nerve and vessels. Now, this is the video demonstrating the glenohumeral joint. By the way, these videos are from Dr. Aanchal, and we just ask the patient to keep the hand on the thigh, palpate for the spine of the scapula, put the probe on the spine of the scapula. Okay, she's coming from down, moving little up, looking at the head of the humerus, moving little up, posterior. Okay, and look for this is the head of the humerus. This is the head of the humerus, giving attachment to the infraspinatus tendon. This is the infraspinatus tendon getting attached here, head of the humerus. This is the labrum, the posterior labrum. Okay. And this is how we evaluate the posterior labrum and the infraspinatus. After that, we keep the probe in this short axis. We look for the two tendons, the bulky muscle and tendon. This is the infraspinatus, and the smaller one is the teres minor. So we look for that too. So this is how the shoulder examination is done. We are able to evaluate a lot of pathology with this shoulder examination. And what are the pathologies around the shoulder? There could be related to the muscle and the tendon pathology, which may involve any of the rotator cuff tendons. There could be joint pathologies involving the AC joint or the glenohumeral joint. There could be bursal pathologies involving the SASD bursa or the subcoracoid bursa or adhesive capsulitis. So in ultrasound, we need to differentiate between the tear and the tendinosis. How do we do that? I know you must be knowing this. The tear is completely anechoic, very well defined. There could be volume loss associated with the bony irregularities. While in tendinosis, these areas are hypoechoic. You cannot very well define the area of the tendinosis. The tendon might appear little bulky, increase in size, and the bony cortex is usually smooth in cases of the tendinosis. So bony irregularity basically could be an indirect sign of the tendon tear. So this is how the pathologies look in ultrasound. The tendon tear, which is completely anechoic, you can very well identify the area of the tear. While in tendinosis, you exactly cannot mark the area of the tendinosis completely. There is increased in the thickness of the tendon in the area of the tendinosis. So rotator cuff tear, the causes are multifactorial. It could be due to overuse or due to some traumatic event, abnormal acromial arch. We have seen in the MRI reports written that acromial arch type 2, type 3, type 1. So whenever there is type 2, type 3 acromial arch, it presses on the supraspinatus, and tendon are more prone for tears. It could be age-related or some related to some metabolic conditions. Tear could be the partial thickness tears, usually a very common cause of the shoulder pain, and it results in limitation of the activities of the daily living. And it has been seen that the ultrasound and the MRI, they are comparable accuracy. You can diagnose many pathologies with the ultrasound as so, majority of the tear of the supraspinatus tendon, they involve the most anterior most, and the distal part of the subtendon at the level of the rotator interval. The posterior most area at the junction of the supraspinatus and infraspinatus, they are prone for the degenerative tear. So, majority of the tears are because of the chronic attrition and are associated with the cortical irregularities. So partial thickness tear could be articular surface, could involve the articular surface, could involve the bursal surface, or sometimes it is interstitial within the substance of the tendon. Or there could be complete full thickness tear with the retraction of the tendon, or there could be massive rotator cuff tear. So whenever the patient comes to us, we take the complete history, do the complete evaluation. We see the site of the pain, whether it's enterolateral pain is usually associated with the impingement and the rotator cuff tendinopathies. And we ask for these in the history that if the patient is able to do the overhead activities, night pain, difficulty in sleeping with that, along with the shoulder examination, neck examination is must to rule out the C5, C6 radiculopathy. These are must look for any comorbidities in the patient. This is a good screening test to evaluate the range of motion of the shoulder, the Apley scratch test, and where the patient attempts to touch the opposite scapula, thus testing the abduction and external rotation, and adduction and the internal rotation. So range of motion assessment is must. Then we look for the specific tendons. We look for the supraspinatus tendon or the tear with the help of the empty can or Hawkins test. All these tests are done in the OPD, and we try to make a diagnosis. This is just a pictorial thing to see that bursa lies above the supraspinatus tendon. Between the supraspinatus and above is the deltoid. The bursa lies in between that. So any tear which involves this area is the bursal side tear, and any tear which involves the footprint of the attachment here at the level of the where it's the tendon is attaching to the greater tubercle. This is the articular side tear. So again, this is the bursal side tear. This is the interstitial tear. Interstitial tear lie between the tendon. They are not extending to the bursal and the articular side. This is a pictorial representation of the full thickness tear, where we cannot see the ends of the tendon. So in ultrasound, this is how we see the tendon. This is a ultrasound of the supraspinatus tear. We can see that anechoic area within the fibrillar tendon. So this is suggestive of the tear, and it is at the level of the this articular area. We can see the bony irregularity here. So this is suggestive of the supraspinatus tear involving the articular surface. Again, this is the supraspinatus tear, which is extending till the capsule. This is a then tendon involving the bursal area. There's the tendon. This is the bursal area. This is the deltoid, and this is the tear which involves the bursal side of the supraspinatus. Then we look for the intrasubstance tear. Then the full thickness tear, where we cannot see the ends of the tendon. This full thickness tear are usually associated with this. There will be the volume loss. Normally, normally the tendon has this convexity. Supraspinatus tendon has this convexity, but whenever there is this tear, that convexity is lost. There will be, if the tendon should come like this. Okay, but because there is a volume loss, this convexity is lost. This is suggestive of the full thickness tear of the supraspinatus. At the level of the tuberosity, we can see the bulged tuberosity sign. We cannot see the end of the tendon. These are the pictures representing the complete tear of the supraspinatus tendon. Supraspinatus tendon is the most common tendon to be involved in the pathologies. Isolated tear of the infraspinatus or the subscapularis is very rare. It's usually associated with the supraspinatus tendon. And whenever there is subscapularis tendon tear, always look for the biceps tendon subluxation. It is associated with the subluxation of the biceps tendon. Okay, then for infraspinatus, this infraspinatus teres minor, these are the external rotators. So we examine the patient, look for the external rotation, whether it's weak or painful. And infraspinatus tendon, again, the tendinosis. We can see the area of the tendinosis or the infraspinatus full thickness there. They can be evaluated with the ultrasound. The subscapularis, a patient will complain of pain in the internal rotation. The belly press test will be positive in cases of the subscapular tendon pathologies. And this is suggestive of the subscapularis tendon tear with the bone avulsion, with the bone chips off along with the tendon tear. So this is the subscapularis tendinosis. Sometimes there could be calcific tendinosis, calcific tendinitis within the tendon. Because of the chronic hypoxic injury within the tendon, there occurs the metaplasia of the tendon. The tenocytes, they are converted to the chondrocytes, resulting in the calcification within the tendon. And sometimes there could be this soft calcification, sometimes there could be hard calcification with the subacoustic shadowing, though these are common findings which are there. Sometimes these calcifications are not picked up with the X-ray, but they can be seen with these type of, specifically these type of calcification. When the calcification is little slurry, is not very well formed, those calcifications are not picked up with the X-ray, but can be picked up with the ultrasound. So we look for the biceps tendon, the speed test. Patient has complaints of tenderness at the coracoid. There will be fluid around the tendon in the short axis and in the long axis. Biceps fluid alone, it has 60% positive predictive value of the rotator cuff tear. Whenever there is fluid around the biceps tendon, always suspect that there is rotator cuff tear. And
Not audible.
Dr. Namrita, we can't hear you.
Hello, not audible.
Dr. Namrita, we just lost you on this slide. It was going okay.
okay, still here?
Yeah, a little
Hello.
bit, little bit.
Can you hear me now?
Yes, but the voice is very low. Your voice is breaking and
Voice is
the
not clear,
volume
madam.
is very low actually. Is it? You're audible, but your voice is breaking. Is that the internet issue or? I think there's some disconnection or yeah, we heard this calcific tendinosis. That was clear. Yeah. And in this slide, you were explaining the effusion and then we lost you. Yeah, Dr. Namrita, your voice is breaking too much. Do you want to connect maybe the hotspot or if there is an internet issue? We can't hear you. So Dr. Namrita has some she will disconnect and she will reconnect. In the meanwhile, I'll ask few questions just to check, how much you are hearing. You can type the answer in the chat box. Which tendon do we see between lesser and the greater tuberosity? I'm waiting for the answers to be written in the chat box. Biceps tendon, good job. Okay, so the next question is, which test do you do to checking which clinical test do you do to check the biceps tendon? Which there be a possibility the biceps tendon speed test. Good job. So the next question is, what kind of the test, which clinical rotation will be limited when you, let me allow Dr. Namrita, which rotation will be limited in frozen shoulder or adhesive capsulitis? What all movements which we discussed? External rotation, good, and what other movement? External rotation is the first one to be involved. Abduction, yes. Yes, that's right. Okay. And meanwhile, if you have any questions from your end, then you can keep typing that. We'll take that in the end once Dr. Namrita is joining. So when we do internal and external rotation of the hand, which tendon are we checking in the dynamic settings? When we are doing internal rotation and the external rotation, subscapularis. Good. I think everyone was awake. Everyone was hearing and focusing. That's good to know. Okay. And other than the glenohumeral joint, what other joint do we examine in the shoulder joint? AC joint. Good job. Dr. Namrita, we can see your slides. So there is again a voice problem. Do you want to connect from your phone? Maybe you can speak and then probably we can have, I can mute this one and then you can try from your iPhone. Because still there is a voice issue. Or let me know if you want to ask me to
Can you
share the slides.
Can you hear me now?
We can see the slides, but you can try speaking. Then let me mute your slide. Yeah. Try presenting now.
Can you hear me now?
Yes, we can hear you well. We can hear you well.
Okay.
Go ahead.
Thank you. Thank you so much. Okay. So I was talking about that whenever there is fluid around this.
And by the way, Dr. Namrata, everyone was listening to your.
Okay, that's good.
Yeah, I was saying that everyone was listening to your slides very well because they were answering all the question I asked.
Okay,
So
that's
you're
good.
doing great job in explaining.
That's good. Okay, so I was talking about the biceps tendon. Whenever there is fluid around the bicep tendon, whether you are able to appreciate that fluid in the short axis or the long axis, the biceps fluid alone, this has 60% positive predictive value for the rotator cuff tear. Okay, so always look for any tear in the rotator cuff whenever you see the fluid around the biceps tendon, because whenever fluid is there in the glenohumeral joint, that fluid is reflected along the biceps tendon because of the biceps tendon has that intracapsular origin. Okay. So whenever the fluid around the biceps tendon is associated with this fluid in the SASD bursa, it has 95% positive predictive value for the rotator cuff. So these are basically for making a diagnosis. So whenever you see the fluid in this SSD bursa along with the fluid in around the biceps tendon, always think in mind there has to be some rotator cuff tear, because it has 95% positive predictive value for that. Okay, so sometimes by there is this Popeye sign. I have till now I have seen only one patient in my lifetime who presented to me with the complete biceps tendon tear, and this the in between these two, the greater and the lesser tuberosity, you there will be this groove will be empty. You will not be able to see tendon, and in the long axis too, you can see the anechoic, this complete full thickness tear of the biceps tendon along with the retraction of the tendon hair, and patient will present with this bump in the forearm, which is known as Popeye sign, and it is usually associated with some kind of trauma. So now we come to the this okay, now we come to the this bursitis. We look for this impingement sign. We do the dynamic impingement maneuvering in the ultrasound guidance, and we can see the fluid within the SASD bursa. Basically, this is the deltoid, the supraspinatus tendon, and just in between these two tendons, you are able to see the fluid, which is suggestive of SASD bursitis. And it usually occurs. What are the causes of this bursitis? It can occur in the rotator cuff tear. Sometimes can be a part and parcel of the inflammatory arthropathy, like in gout, rheumatoid arthritis. Sometimes septic causes are there. If again presence of bursal fluid alone, it has 70% positive predictive value for the rotator cuff. If there is bursal fluid along with the biceps fluid, it has 95% positive predictive value for the rotator cuff tear. Now, treatment depends upon the age, the acuteness, whether it is acute pathology, chronic pathology, and what type of pathology. Okay, so this calcific tendinitis, this is a very common cause of the shoulder pain, and usually acute tendinitis usually respond to the conservative treatment, but sometimes these chronic tendinitis, they do not offer respond to conservative treatment. In these cases, we can go for the babutaging of the calcification within the tendons, especially in the stage where there is that slurry-like calcification within the tendon. Sometimes calcifications you can pick up in the X-rays, and that correlates well with the calcification within the tendon in the ultrasound with the this acoustic shadowing. And sometimes these calcifications are not seen in the X-rays. Only with the ultrasound you are able to make a diagnosis. So we break the calcifications with the saline, and while coming out, inject little bit of steroid within the bursa to prevent that inflammation of the bursa with the calcium deposits. Okay, so again the uh, calcifications with the tendon, we have been able to ultrasound guided babotage of the calcification can be done. Okay, then we all do a lot of the regenerative interventions for the rotator cuff pathologies, the platelet-rich plasma therapies, or the bone marrow concentrated therapies for the different type of tear, different pathologies within the shoulder joint. We all know that PRP, it harnesses that regenerative power healing potential, and it results in. So there are a lot of literature which, and even we have so much of personal now, we have seen personally doing, we are doing since so many years, we are doing this PRP and the BMAC interventions for the rotator cuff tear, rotator cuff tendinopathies, and it gives really brilliant results when done in the correct patient and when done under proper guidance, not the blind procedure, but the ultrasound guided interventions. So it is very effective procedure, and it leads to significant decrease in the pain and improve the shoulder functions. So we have a lot of data available with us, uh, which proves the role of the PRP therapy for the rotator cuff tears. Now, once I'll talk a bit about the rehabilitation part. I do a lot of, in fact, the bone marrow interventions too for the uh, um, more than 50-70% of the tear, almost complete tear without the retraction. I do bone marrow concentrate therapy for those type of tears, and the results are brilliant. But we have to always keep in mind the post-op management, the post-procedural management in these patients. The first thing, because of these regenerative therapy, we usually avoid the NSAIDs for the pain management. Only the warm fermentation, paracetamol, or the tramadol are very good for controlling the pain. And if there is a large tear within the rotator cuff, always give a sling to the patient for 7 days or so, so that once you have treated the pathology, you give rest to the tendon so that the healing can occur. And once the healing has started, then you start with the ROM exercises, and progressively with the weights for the complete strength of the tendon. So these are the things which are routinely done. This is the needle within the area of the tendinosis in the supraspinatus, and we are injecting the platelet-rich plasma in the area of the tendinosis here. So this is what I just wanted to share. I'm open for questions.
There is one question. They say, do PRP/BMAC helps for full thickness tears?
See, PRP will never help for the full thickness tear. See, I follow a different protocol in that Regenex protocol. Yes, the BMAC therapy is able to heal the full thickness tear, but that should only be done for the non-retracted tear. Once the tendon full thickness tear is retracted, tendon is retracted more than 1 centimeter, you patient will need the surgical treatment. So you have to choose your patient wisely for doing these bone marrow therapies, because obviously these are costly procedures, and you cannot blame these procedures by selecting the wrong patients. Okay.
Yes. PRP, so we should not try for full thickness tears.
No, PRP
And
will never work for full thickness
will
tear.
never. Yes. So always try it for partial tears. And other questions
Personally,
from
because
the
Dr. Aanchal,
students?
I am doing that Regenex thing. Personally, I have seen that for full thickness tear, yes, BMAC works,
Yes.
but only if the retraction is less than 1 centimeter. Okay.
And we
So
have to check that in MRI.
for you, when you people are starting your career, don't try to treat the full thickness tear. Go only for the partial thickness tear. Okay.
Yeah. But even
The
in the
take
late in the
messages for
practice, if
you is
someone
that.
is not doing BMAC,
Ha.
if someone is not doing BMAC, they should not go for
Don't
any
don't
therapy
don't
for full thickness hair.
don't go for PRP.
Yeah, and I'll advise keep practicing. For exam purposes, you will be asked to show these structures. So
Hmm.
just keep practicing on patients whenever they come. Try to do all the like dynamic exams. Try to check all the structures so you
Actually,
guys can
try
keep
to
practicing.
evaluate all the patient in ultrasound. In the starting, you will take little
Yes.
more time, but later on, it will take only hardly 5 minutes to
Yeah.
complete the shoulder examination and ultrasound.
Yeah. You showed one video in which you completed all the examination in
Everything,
just one
yeah.
video. But it's
It's
yes,
just yesterday
habit
only
of
I just clicked that video.
yeah. Yeah, I see that you have that very high generation ultrasound
Ultrasound, yeah, ultrasound machine is
visual
very
showing.
nice. Yeah,
Yes. So that's good. Actually, great job, Dr. Namrata. You explained
thank you
things
so much,
really
Dr.
well.
Anshul.
Good effort,
Thank you so much.
and I'm sure all the students understood. We don't have any more questions, and I'm glad we finished in time. So thank you. We can
Thank you so
say
much.
good night to everyone. All right.
And if you have any
Okay.
questions, dear students, you can connect to me anytime. I'll be very happy to answer your queries. We all are there to help you all, right?
Yes.
Thank you
All
so
right.
much.
Thank you, everyone. And yes, absolutely. Absolutely. All right. Thank you. Good night, all.
Okay, good night. Bye bye.